just some information about where we are in our understanding about the infectious disease Ebola. So how infectious is it? For those of you who remember your epidemiology, or for those of you who never did epidemiology, there's something called an R naught. That's what that R with a little 0 subscript is called. An epidemiological term which is used to show or indicate how infectious a particular infectious disease is, and it's the number of people that will be infected by each infected individual during the time that that individual is infectious. All right, so it's an over time number. So measles is considered a highly infectious disease. So during the time an individual is infected with measles and infectious to others, they will infect on average 18 others. So that's a high R naught. HIV, relatively lower. Each person infected with HIV during the time of their infectiousness to others will infect on average 4 others. Now realize the time you're infectious with measles is much shorter than the time that you're infectious with HIV. So this is an over time calculation. HCV is hepatitis C virus, which for people of the baby boom generation is a very important infectious disease. Many of us who are of that age are infected with hepatitis C virus. Again, it's a chronic infection, so over a much longer period of time, but each of those infected people will infect on average just 2 others. So how, this is a question for you all, what is the R naught of Ebola? Do you think?
25.
25, so higher than measles.
50.
50? So you're going much, much higher.
1.5.
1.5? Actually 2. So it's not a highly, highly infectious disease like measles. Now part of that is because people who are infected with Ebola during the time that they're infectious is quite short, because it's got quite a short course of illness. All right? But it's not as infectious as some other things that we maybe don't think as being quite as problematic. And there, of course, are reasons for that. Right? The other thing about Ebola, which makes it less easy to be infected with, is that it requires contact with body fluid. It's not that easy. Okay. Of course, the other thing, or among the other things that matters, is how severe it is for those who are infected. That, of course, matters a lot. So a high fatality rate, though, frankly, in this most recent outbreak, the numbers have actually proven to be somewhat lower than was previously believed. So we used to think about Ebola fatality as 70 or 80%. Turns out not to have been true in this particular outbreak, which of course could be a function of this outbreak or could be a function of our better ability to treat it. Matters who's at risk, of course, and the greatest risk, and we saw this in the way the epidemic spread both in West Africa and, of course, in the people who were infected in this country. The greatest risk is to those who are the caretakers of the sick, that is the healthcare workers, and especially in the developing world, lower middle income countries, those who were handling the bodies of those who were deceased. The other thing that obviously makes us think differently about diseases like Ebola now than we used to is how little borders matter in 2014, now 15. So when I went to public health school, was in, you heard, 1987-88, which was at the height of the HIV/AIDS epidemic, or early on in the height of. And among the things that I'm carried to this day was a lecture by somebody from the U.S. Department of State, who came to talk about how they were thinking, so the State Department, and it's not the health folks, but the State Department, about the HIV infection, which everybody knew was raging in Africa. And this particular person talked about a range of options available to us as a matter of foreign policy, us being the United States. And he said that there was talk about just ignoring the fact that it was infecting huge parts of countries like Zaire, now the Republic of Congo, and letting it burn out was the comment. It's just, forget about that big part of the population. They'll infect each other, many people will get sick and die, and we'll sort of start again. So it's over there is the point of that story. It's not our problem. Now, since then, luckily, there has been a change in thinking about the importance of not thinking about that as being over there and us being over here. Bill Clinton and subsequent presidents identified HIV as a national security issue, and I think we've been treating the Ebola outbreak along those lines as well. So the point being, we get on airplanes and fly pretty much anywhere else on the face of the globe in a very few hours in 2015. All right, so here is actually from, why it's important for me to be able to walk. This is taken from the CDC website just late last night. So this is as up to the minute as I can make it for today. And I wanted to show this, sorry it's a little bit blurry, but this gives you a sense of the outbreak, the most recent outbreak of Ebola in West Africa. And if you can't see it, I'll read it out to you. So it says countries with widespread transmission, which are of course the ones those are the ones that matter. There really are no countries with small transmission anymore. Guinea, total cases, suspected, probable, and confirmed is the first column. Says for Guinea, 3,566. The next column is laboratory confirmed cases, 3124 in that case, and total deaths, 2,348. So you can do that math. 2,348 of the 3,500 cases, that's the fatality rate, quite high. The second row is Liberia, 10,042, 3,151, 4,486. So 4,500 out of 10,000 deaths. And the third row is Sierra Leone, 12,223, 3,865. So 4,000 out of 12,000. So that's a lower rate of fatality. Important to me about what I'm interested in sharing with you today is this total deaths number. So in this outbreak, since the beginning of it last year, there have been fewer than 11,000 deaths, which is a surprise, I think, to most people, because you think of this scourge that is making its way, burning its way through West Africa, and we're very worried about epidemic. Those are not how we think about major world pandemic infection numbers. So it's harder to get than I think people have appreciated. The next slide is a kind of blow up. It's a blow up of that little smaller map that shows you the area of the world where this has been the biggest problem, and it's those three countries. So the darker the color, the largest numbers of cases. All right. So how many of you read this book? Only that many? It's going to really undermine what I'm about to say. So just pretend you've read this book. So Richard Preston wrote a national bestseller, published in the early 1990s, which was, in a way, it was at least, as he wrote it, and it was marketed, a terrifying true story. That's the important part of the take-home here. A true story, and if you read it, it was quite harrowing. I read this book when I was doing some other work for the federal government that made me really concerned about the way people died, about the way this infection spread. So in the aftermath, or the realization of the current epidemic outbreak, he was interviewed. This is from an interview in the New York Times, October 19th of last year. And so when the Ebola outbreak in West Africa began to escalate, he said, I need to get back to Ebola. I've got to cover this. So as it says here, Mr. Preston first incited public fears about Ebola 20 years ago with the hot zone. His thriller-like narrative that details the virus's origins and scientists struggle to understand and stop it. The book, which has sold 3.5 million copies, although from the numbers of hands that were raised in the room, maybe nobody here, okay, could perhaps be classified as dystopian nonfiction. And I certainly read it that way. Stephen King called it one of the most horrifying things I've ever read. Right? So I guess that means it's really scary. With fears about Ebola rising once more, the hot zone has been in high demand. Mr. Preston's publishers released 150,000 more copies in recent months, and the book has reappeared on the New York Times bestseller list and number 3 on Amazon. All right, so that's the way that the public understood Ebola. I'm saying that for reasons that will become clear in a minute. So later on in the interview, some of your descriptions of the virus and its symptoms in the hot zone have been called inaccurate and hyperbolic. Are you planning to release an updated version with information related to the current crisis? Yes. I'm dying to update the book. Poor choice of words, but okay. I want to make the clinical picture of the virus more clear and accurate. In the original hot zone, I have a description of a nurse weeping tears of blood. Very memorable. Passage in the book that almost certainly didn't happen. When a person has Ebola, the eyes can turn brilliant red from blood vessels leaking and blood oozing out of the eyelid. That's horrifying, but it's not something with tears of blood running down your face. I want to fix that. The other thing that has happened with Ebola today is there have been, and he goes on to say, lots of better understanding of the science. Okay, so he's admitting that there were a little bit of inaccuracies. So, now, jump forward, and this is from, you can find lots of things like this. I picked one. This is an infectious disease epidemiologist who said, the hot zone created the worst myths about Ebola, the utterly wrong descriptions of the symptoms. And you can read that yourself. I don't need to read it out to you. It's, I think, relatively legible, straightforward. Okay, it's not the way he described it. And maybe most important, it isn't something that is likely to be, and certainly isn't currently, an airborne infection. That would make it a much bigger problem. Then it's like flu. All right? So, though this trope is often traced back to the movie Outbreak, Preston clearly suggests that both Zaire Ebola virus and Reston Ebola virus, those are just 2 strains, can be airborne. What he never discusses nor clarifies is that the evidence for this potential airborne spread is really thin, blah, blah, blah. So it's really, the argument that many people have made is that we have been introduced to a disease that is not nearly as problematic as we've been led to believe. That said, right, it's still an infectious disease that we don't have great treatment for, and we certainly don't have a vaccine for. So I want to now step back. How do we think about responses to infectious disease? One is we vaccinate when we can those who are not yet infected. And there's a lot of work going on. People at Hopkins, as well as University of Maryland, actually are very heavily involved in the trials to try to produce a vaccine with some very promising early results. When there's no vaccine, among the things we do is isolate those who are infected so they don't infect other people. So the R naught is even less of a problem. And then, of course, when there's effective therapy, then we use it. And of course, we heard a little bit about the very few doses that may have been effective for people in the early outbreak last year. So what do we do about Ebola? And now I'm going to shift gears, as you'll see, and talk a little bit about the way we think about the ethics of how to control infectious disease outbreaks in the context of public health. So now I'm going to put on my professor hat. I wasn't before, believe it or not, but now I will be. So there's a particular tension in liberal democracies, and that's a small L liberal, even though it starts the sentence there. It's not meant to be liberal like liberal versus conservative. Okay? Liberal democracies, liberal states like the United States, like Northern Europe, right, have responsibilities that are in tension. Serving the needs of people both individually, our rights, right, to be free to decide what we want to do with our bodies, and our being part of a collective. So we want to serve the individual and the whole, taking into account various aspects of both. In liberal democracies like ours, there is much less justification, just because of the way our systems are set up, for coercive policies. We want to do things that are least infringing on others in order to accomplish public health goals. So coercive policies means we force you to do something against your will. If I hold a gun to your head and say, give me your wallet or I'll shoot, your handing over your wallet is not a voluntary act. You've been coerced. Okay, that's under threat of harm. So that's what we mean by coercive policies. And we have much greater emphasis on transparency, what we're doing and why we're doing it, and on the participation of the public in that discussion, although sometimes it doesn't seem like that's happening enough. So to sort of summarize that, there's a presumption in our country and others like us of liberty. And we limit that presumption of liberty only under some circumstances. So now we're going to talk about what those might be. So we, in our lived experiences related to this part of our political commitments and political philosophy, liberty has two kinds of meanings. One is the kind of liberty I was talking about. You're free from the state interfering in your actions. So that's the kind of thing we talk about in the Bill of Rights, freedom of. So when you say freedom of speech, that freedom is the state isn't allowed to tell you you can't talk, but it isn't, right, a right for the state to demand of the state that they give you the auditorium and the people sitting in the seats and the podium and the microphone. That's not a negative right. That's not a liberty. That's a kind of positive right. Right? So that's the kind of freedom we mean. And on the other hand, we also have freedom from the state doing something to our bodies, so sticking something into us. Forcible vaccination would be an example of that, which is why we're having all this consternation around vaccine mandates. What does that mean? Okay, it's both a non-intrusion and a kind of non-limitation of liberty. All right, so let me give you a little bit of an example of how we've come to this. And I'm using just some legal cases. We could do this lots of other ways. Any lawyers in this crowd? Constitutional lawyers? Hopefully not. So the place that people in my world look at for the beginnings of what we call the commitments in the health sector to informed consent is a case from 14, called Schlorendorf v. Society of New York Hospitals. So this is the highest level court in the state of New York, so not Supreme Court, but very high in the state courts, which 1914, a long time ago, over 100 years ago now, where in the decision, which was brought by Mrs. Schlorendorf, who had agreed to go under general anesthesia, which in 1914 was no small thing, for an examination of what turned out to be fibroid tumor. Okay, an examination. When she was under anesthesia, the surgeon said, this needs to be removed. They did a hysterectomy. And when she woke up, she was told, we took out your female parts. And she said, I didn't agree to let you do that. So a cause of action was brought by her against the hospital for battery, unlawful touching, which then led to this statement, which was at the time really novel, first time in legal courts related to health. As you see here, every human of adult years and sound mind has the right to decide what shall be done to them. You get to decide for yourself. Really important. Seems quaint today, but 100 years ago, that was a very big deal. Public health, right, the different thing. So that's about what happens to you in the context of your health care. Second, and these are just two cases in what could be much longer discussion. If we were doing a law seminar, we would have a very different conversation. Two important cases, one that predates Schlorendorf, which is famous in the public health world, Jacobson v. Massachusetts, which is about the state's authority to enforce compulsory vaccination law. So arguing at the U.S. Supreme Court level that the state of Massachusetts could limit the freedom of individuals for the common welfare, and that limitation is subject to the police power of the state. So the state can force you to be vaccinated, even if it's against your will. That, I would say, saw its unfortunate nadir in a case in 1927, Buck v. Bell, infamous Supreme Court case, in which the Supreme Court upheld the state of Virginia's compulsory sterilization of women who were deemed to be unfit, intellectually disabled, for the protection and health of the state. So this is public health protection taken to an extreme, which is no longer good law, as you might guess. But this shows you the extent to which we might think about how far we go in infringing on the liberties of individuals, and in that second case, reproductive liberties of individuals for the good of the public's health. So this is a famous case where the court said, 3 generations of idiots is enough. It's an infamous Supreme Court decision. All right, so how do we think about this in the context of infectious disease? So what are the acceptable limitations or infringements of liberty that are acceptable? As I showed you already, I think, a fundamental question for how we think about ethics in the context of public health. It's important to remember that we primarily bring this out, right? The actions we take or the refusing to act on the part of the individual must pose risk of harm to others. So we tend to only infringe individual liberty when the thing that you do or refuse to do imposes risk of harm to somebody else or to the collective. So I can't punch somebody in the nose, that's a limitation of my liberty. Similarly, in public health, we say when what you do or fail to do causes harm to others, we're going to restrict your right to decide to do whatever you want for yourself. So we have to answer questions about that. How great must the risk be? How significantly will it affect other people? And how much infringement is justified? So the way we answer that question, framing it in the ethics of public health, and we're going to get to Ebola in just 2 seconds, I promise, is we only can justify infringement when it's necessary to achieve our stated public health goals. Okay? We can't achieve that stated goal some other way. Second, it will be effective in achieving those goals. It's proportional to the goals that we hope to achieve. It's the least infringing approach possible, and we justify it in a public way. So keep that list in mind as we go through what's about to come. I'm going to now visit with you about some things that you'll remember from the media. Any questions? I've been talking a lot. We're going to move from lots of words to some pictures in a second. Okay. So let's talk about some public health messaging. You must, I'm sure, remember the case of Thomas Duncan in Dallas, who was infected in Africa, came to the United States, infected, and then went into the hospital, subsequently died. But stayed with friends, family, before he went to the hospital, and so they were exposed. So you, I'm sure, remember this. So here's a picture. I like this picture, but I think it's instructive because it shows you. So it's somebody bringing food to the family, and you can see by his body language, right? He's sort of getting only as close as he absolutely must to hand the food to the person behind the door. Okay, so what's the message there, right? That's about as other, right, as you can get. And the headline, this is from the New York Post, whatever you think about the journalistic quality of that source. Ebola family under armed guard after trying to leave quarantine. So quarantine is about as strong as we get. Forcing people to stay someplace. They can't leave. Right? Quarantine is keeping somebody in isolation away from others. So I want to think about whether, in light of that picture and what you know about the case in Dallas, whether that behavior, that decision to quarantine that family was necessary to achieve this, whatever the stated public health goal was, which frankly wasn't all that well articulated. What do we want to achieve by keeping these people in isolation in a small apartment, unable to get access to things that would otherwise be available to them? Would it be effective? Is it proportional? Is it least infringing? And is it publicly justified? Rhetorical question. Second example, you may remember the case of the healthcare worker. So this is the story of what's her name, the nurse Casey Hickox, who came back from having been a volunteer in West Africa and was told she needed to stay in quarantine until it was determined that she was not infected, right? She objected to that and said, I won't submit to quarantine and I don't have to, on the argument effectively that it didn't meet the criteria that I just listed for you before, okay? And you can't force me, more or less. It's a picture of now presidential candidate, Senator Rubio from Florida, talking about her being a hero, actually, for having done what she did, and I would agree with that. As you'll see in a second, that just happened to be the screenshot that I pulled. Okay. So that's what we saw in the some messages received from the outbreak here in the United States, right? That's what we're really focusing on for this particular part of my talk. The second is how the government portrayed what we ought to do, what it ought to do, what our society ought to do in the context of people coming back from having worked in West Africa or having traveled from West Africa after having been exposed. So there was a lot of confusion, you may recall, where the governors of New York and New Jersey together held different press conferences, multiple press conferences, where they announced what the rules would be about quarantine, and then effectively recanted after the Casey Hickox story and said, well, we're not going to be quite as restricted as we said we were. So there was all this back and forth and unclarity about what the policy was, what it should be, what exactly are we supposed to take from that as a public. I would say that the government's not quite sure what the right answer is. That's the problematic take home. Most recently, and this is just from April the 11th, so just a few days ago, and I should have said this at the outset. April 6th to 12th was National Public Health Week in the United States. Just FYI, we just have finished that. This story was in the New York Times on April the 11th about how the substantial resources the United States sent over to West Africa to do, among other things, build clinics to treat those who were sickened by Ebola, except that we built a lot of clinics that have nobody in them. It came very late in the outbreak, and it seemed to be, at least at the time, the wrong thing. Right? Empty Ebola clinics in Liberia is seen as a misstep in the U.S. relief effort. So we built lots of new, gleaming clinics with beds in them and no patients to occupy them. So we're a little out of step with what needs to happen in the context of this particular outbreak. So it's understandable, getting to my trope here, that there's a lack of understanding, understandable fear and confusion about what the right thing to do is.
But that's just by the politicians. What about
Absolutely, we're getting there. And that's right, that's by the politicians. So whoever said that, thanks. So, and I'm happy to make you say more about that. So, your comment makes me think politicians don't know what they're talking about, would be the subtext. Okay, do you think that's the sole explanation?
No.
Okay, so say two more words if you don't mind.
Well, they don't know. We don't know.
Okay, so it's not that they're somehow motivated by some other.
Well, they're politically motivated.
Aha.
Yeah, they
Okay,
are.
that's what I thought you were trying to get to, and so I think part of the answer is they didn't know. It was a fast-moving story that there wasn't a lot of information, frankly, or good information, but also that they had other motivations to show that they were strong. It was the fall of 2014. What was happening in the fall of 2014? There's an election about to happen. All right, so there's all sorts of dynamics here, and that's important to acknowledge. So it's a bad combination, I guess is what I would say, of limited information combined with motivations that may have been for other than good public health practice. All right, so what's the public to take from this? So I started with Richard Preston and the Hot Zone. And that's an old book. That's 1994, I think, was the publication date. So what are we to take from what we can learn by reading from those who cover these events in ways that we can consume that information? What are we to take from that? And this is a story from the Poynter Center, which is actually a journalism center that focuses on these kinds of questions. How do we get good quality journalism on all sorts of issues, but health among them? And as you see, this headline says, journalists struggle to balance reporting on Ebola with HIPAA. So HIPAA is the health, information, privacy, and accountability, and too many A's and too many B's. It's what you have to, it's the law that protects your personal health information when you go to the doctor, when you go to the clinic, when you show up at a hospital. So it's about health information, how it must be treated to protect the individual's privacy. So this story relates to how the media reports on when there are very few cases of people infected with a scary infectious disease, should they share the name of that person? That's to get there. Sorry, it took a long time, but that was the point. So I talked to reporters about exactly this question. Very interesting. National Wire Service reporters who wanted very much somebody to say, when a disease is really infectious and has a high fatality rate, protections of individual health information ought not apply. I said, well, why would that be the case? What about that's how we, exactly the same question would apply to HIV. Certainly in the early days of that outbreak, we didn't understand how to manage it. Do you think we should then report the name of every person who's infected? What will that do? Right? It'll drive people underground. It will make people pariahs. It creates a huge amount of stigma. Well, I don't think that's an appropriate thing to do. And the pushback was the public's health is at stake and all bets are off. And there are certain kinds of diseases or certain combinations of factors in infectious disease that may trigger that justification.
Who's authorized to enforce that act?
I've only heard that there was a question, but I didn't hear
Who
what
is
it was.
authorized to enforce that act?
That's federal law.
What is there, an agency that?
So Department of Health and Human Services, I think, is probably the technical answer. But if you violate HIPAA, the institution is on the hook. So if Hopkins violates HIPAA, there's a per episode fine that gets levied. If health information is stolen, like from a website, there are very large fines levied. I'm not exactly sure where the enforcement comes from, if that's what you're asking, but I think it's HHS would be my guess.
Are there jailing penalties?
Jail?
Right.
I think it's only money,
Only money.
if I had to guess. I'm not 100% sure of that, but I'm pretty sure it's just money. But it's a way to protect our health information. So if if a news outlet reported the name of Thomas Duncan before he had disclosed himself, or that it had come out from the Dallas hospital, which I think is actually how it happened, the newspaper would have been violating federal law. So in all of these cases, interesting, all the names we know of the people who were infected were self-disclosed, and that's totally acceptable. You can disclose your own information, that's absolutely acceptable. And the question was, well, what if people won't disclose their status? Don't we have both an ability, and the journalist would say an obligation, to disclose that information to the public in order to let people protect themselves? If you think about where that might lead, if the answer to that were, yeah, sure, and here are the criteria that would satisfy it. I couldn't actually think of a case where I thought that would be appropriate. Independent, actually, of the law. The law is the way that gets to, well, what happens if we do this? But even if there were no law and it was an ethics question alone, it would be hard for me to justify that. Yeah.
What about measles vaccination and the people who are not vaccinating their children for that, particularly with the R factor for measles?
Yeah, so what was the first part?
What about that? Are we allowed to say who hasn't been
That's a
vaccinated?
good question. No.
That's,
Yeah, so I think it would be viewed in the same way. That's a good question, though. I guess the question how we would know that is a matter of medical information, so it would probably be protected under the same rules. Now, what's been interesting about the measles case is that there have been now, there's been a bit of a backlash. So the sort of vaccine hesitant crowd, or the anti-vaccination crowd, seem to be gaining traction. But now there's been a bit of a backlash because with this measles outbreak, people have said it's not right for you to put my child at risk. My child being one who cannot be vaccinated, either because they're too young, so infants, or they're immune suppressed, or there's some other medical reason. So I cannot vaccinate my child, and I rely on the herd immunity, right, the public protection to protect my child. And by you're not doing that, you actually are violating my rights, and there have been some lawsuits proposed, interestingly, to get us to a little bit of that. All right, 2 questions, and I have to be close to you because I can't hear otherwise. That's actually why I'm standing up here.
I was going to ask about a case where individual knows they're HIV positive and has unprotected intercourse with all people, but
Yeah.
doesn't tell them.
Yeah, so they're tested and told that they're positive? Is that?
In that situation, couldn't that person who ends up getting testing positive,
Yeah.
then that's what the legal enforcement have?
Sorry, what's the last part?
Could the person who ends up testing positive then have like some type of or some kind of, I guess, claim or something of some sort?
So when somebody is tested and found to be positive for a reportable infectious disease, right, that information goes to the public health authorities. And then there's a discussion that happens about who your contacts. And those individuals are then tracked down and told that they've been exposed. They're generally not told by whom. So certain information is disclosed, that you're at risk and you need to know you're at risk. And then if you say, well, who's infected that I've been exposed to? And they say, you need to think about who you've been doing whatever you've been doing with. And that's as far as it will go on the same kind of argument, that's information about the individual that ought not be disclosed. So if that person's name were disclosed as part of this contact tracing, then there might be a HIPAA claim, if that's your question. Although I'm not a lawyer, so I'm
Haven't there been cases where people have not reported that they're infected and they've infected people?
Yes. Yeah, and then there have been, depends on the state. So state by state, there are laws that may apply to that sort of knowing exposure of others to harm in that case.
Has anyone taken HIPAA to a court to attempt to judge it unconstitutional?
Not that I know of, but it's not something I follow.
So real quick on the measles, wouldn't you agree that the public would have a right to know the non-vaccination rate in a
And that we,
particular institution or
that we
school?
do know. Well, in a school, sorry.
So a particular school,
Yeah, that's interesting. It's important, I guess you're right. And that we do know, state by state and locality by locality, there's data. But in a school, that's an interesting and good question. It certainly would be relevant to people about what their children are at risk
you
of.
don't need to know who, but the rate
Yeah.
of non-vaccination would
Yeah.
be important.
Yeah,
What about your classroom?
yeah. So you start to drill down, exactly. Although one argument is, people should vaccinate their children, period. Now the issue is, if my child cannot be vaccinated but is at risk, what am I supposed to do about that? And in fact, that has been the source of these suits. You are making a decision that has an impact on other people, me. So that's this other affecting aspect of infringing on individual liberty.
But often it's religious-based, right?
Well, no, so,
Not in California.
well, not a lot of states, right. So different states have different rules about when you can opt out of what are mandatory, quote unquote mandatory, vaccination policies. So every state has rules that require you to show evidence of childhood vaccination before your kid goes to school. But all states also have opt-out. And so the liberality or, the ease or difficulty of opting out is different from state to state. And it turns out, I think Mississippi is the least
Yes.
liberal, which is an interesting,
100% have to be
Yeah.
vaccinated.
and so, it tends to be, West Coast is a little more liberal about this, although California the California legislature just introduced a bill trying to tighten up the mandate because of the measles outbreak and the realization that these are things that should not be a problem in 2015 in the United States. So there are many parts of Africa that have higher rates of measles immunization than California. Shocking, but it's true. So in most other parts of the world, it's a welcome, right? You're giving us an opportunity to vaccinate our children against these terrible diseases that kill them, right? And we run the other way, at least some of us do.
Has it been tested whether a private school as opposed to a public
It's a
school?
great question.
can,
These are state level, so
require
it doesn't matter.
vaccination of all students?
It's independent of the kind of school. It comes from the state, and it's just a way of limiting, it's a way to capture that we're vaccinating kids, because before you can go to school, you have to show you've been vaccinated. It has nothing really to do with school. It has to do with the age at which we want people to be vaccinated. All right, let me keep going. I like that you're asking all these questions. The last little bit of this, and then I'll try to move us to the end of my remarks at least. So you may remember, again, another healthcare provider, physician in this case, came back from West Africa, and then, among other things, went bowling, right, in Brooklyn. So, yeah, I was at a dinner in New York City a couple, 2.5 weeks ago, where this came up at the table at which I was eating dinner, where people were really exercised, and more or less said this, if you're sick, just stay home, don't infect other people. What are people thinking? Why is this such a hard thing? And it's clearly problematic when somebody who's been exposed to this kind of infectious disease doesn't do the right thing. So the question is, what is the right thing? That's what I want to try to get us to. All right.
Do we know, though?
Right, well, we're gonna try to get there. We probably don't know everything we want to know, but we know a lot. So I want to try to help us answer that question in policy, and we're learning more all the time. So I want to also put this in context. So I've been focusing on the U.S. context in which there are very few people, right, that have been infected in the United States, either coming back from or as part of their delivering health care to those who are infected. But this is the real set of problems, right? 7,000 people, one clinic, no running water, Ebola in health systems. That's really the problem here, and it's not an easy fix, but at least it's something that resources and a concerted effort could really help blunt. So how do we do? I've sort of said this, so let me put quickly, right? We were confused. Information that was incorrect was what was out, whether it was because of a book that was written 20 years ago or different things coming from different places. The messaging was really quite slow, and then we had this overreaction, and then a stepping back. It's just very hard to know what the right information was from the government and frankly from the public health authorities. You may remember, all due respect to Tom Frieden at the CDC, that was a really kind of jumbled messaging at the outset, and the White House ended up appointing a czar, remember the Ebola czar, so they took it away from the chief public health authority in the United States and said, we're going to give it to this person who frankly had no public health training at all, but knew how to make the trains run on time. So they turned into kind of an administrative question, which is an interesting, that's a comment about how we reacted in this particular case. And I would say we then engaged in, we tried to engage in some quite punitive practices, sometimes with success, other times people said, sorry, I'm not going to do that, and you can take me to court or do whatever you want, Casey Hickox being that case. So the question then is, to your point, what should we do? And I want to do this from an ethics perspective. I don't want to get too deep in the weeds about the information, but we can do that in a second. Yeah.
So part of the context here, if I remember correctly, there was a healthcare workers in Dallas that became sick.
Caring for Thomas Duncan, yeah.
And part of that blame was around the lack of proper training, that the CDC wasn't really telling the various institutions how to prepare.
Yeah.
So it kind of seemed like we were ill prepared for this situation.
Yeah.
And so therefore, politicians and others kind of said, well, if we don't know what the right thing to do is, let's at least do something that won't kill lots of people.
Let's do something that will prevent lots of people from dying.
Exactly.
Yeah. Well, we hope, right?
Right.
And you're right. So the
So there
question.
was an overreaction, but based on essentially missteps by the government.
Yeah. No, I totally would agree with that. For me, the take home from that is this was you can count on two hands the number of people in the United States that were ever infected with Ebola.
Yeah.
What does this mean for when we have an actual, real outbreak in this country? Very worrisome,
Well,
right?
lack of so the country, which has known about this disease for several decades, had plenty of time to do appropriate preparatory training and
No argument.
practices. And
Well,
yet,
and we went through this actually in the, H1N1 buildup. So we did a lot of pandemic preparing, and we tried to figure out what to do about a large-scale infectious outbreak, but in that case, that's airborne. And so you sort of realize this is a little different in that it required people to don moon suits, before they would even go into specially designed isolation wards. But still, it doesn't give you a lot of confidence about what will happen when the real thing takes place. So I totally agree with you. Let me try to bring this to a conclusion, at least from the slides perspective, and then I'm happy to talk with you about this or measles or anything else. So we want to stem this where it happens, right? Not wait for it to show up in Dallas or anywhere else. And so that means going to where it seems to be in reservoirs, which is in Africa. And for lots of good reasons, we want to build sufficient health systems in low resource parts of the world. That's a good thing, period. So that's a kind of easy thing to say, hard to do. But now I want to kind of switch over a little bit. So the recriminations around what Casey Hickox did, the physician who went bowling in New York did, was about how irresponsible they were, right? But of course, they were put in a position to be acting in a way that some called irresponsible by having done something fairly heroic, right? They put themselves in significant harm's way for the good of other people. No one made them go to Liberia or Sierra Leone or Guinea to provide health care to people who otherwise wouldn't have access to it. I mean, that's a really powerful, heroic, virtuous thing to do. So I say that because I think we've got to be a little more clear about what happens when you agree to do that as a volunteer. That we got to support them when they come back and tell them what that looks like. Okay, that's about reciprocity. Right? You do good things for us as a society, we'll make sure that you're protected in return. And as I've been saying, we need to be really much better at clear messaging that is supported by good ethics framework. Pause for a second here. Among the things that we're trying to better understand in the context of the West Africa outbreak is why some things didn't work. So among the things we know, for instance, that handling of dead bodies is a really bad idea when somebody died of Ebola because of the way the virus is transmitted. And burial practices in many countries and areas of the countries where Ebola is endemic and erupted in this last outbreak, there's a lot of washing and handling and passing of bodies after people die. So burial practices really contributed to the continuing spread. So how do you take those two facts, cultural practices and what we know about the spread of disease, and try to find ways to allow people to practice their culture, but also do it in ways that lead to good public health outcomes? Really hard questions. And in fact, we're trying to do some work around those kinds of questions here at Hopkins with colleagues in Liberia and Sierra Leone. So we're trying to learn from what didn't work and did work as part of the outbreak in Africa. Yeah.
What do bodily fluids include? Do that include sneezing, tears, coughing?
It's not clear. It's a really good question. So I think the belief is mostly it's blood. And I think part of the way that people die with Ebola is it can be very messy. A lot of vomiting, a lot of diarrhea, and bleeding. And so it's not little bits of body fluids. It's quite large volumes. And so it's people are standing in substantial amounts of liquid. And so that's part of what is the way, that's a lot of virus is in the environment. But that's not where most people are experiencing the exposure, right? That's the healthcare workers, by and large, unless people die at home.
And also have any medications been developed or in the process?
It's in the process, is right. And you may remember that when there were other Americans, Westerners, who came back infected, there was a question about who should get access to these highly experimental drugs. And there were very few doses of these new drugs that seem to be effective. There's been some work since then, and there's been a ramping up through various government-funded projects to get production to a place where more people would have access, but it hasn't ever, those drugs have not been run through traditional clinical trials. So that work is actually going on now.
Thank you.
Yeah, that and vaccine development as
Well,
well.
here,
Yeah,
something about the Doctors Without Borders.
yeah.
They were least infected because they wore very protective clothing.
They were not infected
Not
because,
effective because they wore very effective clothing.
yes.
So why couldn't other people who are treating these people with Ebola wear that type of clothing?
And they do, and they will continue to. So part of it, and this is now, my very basic understanding, but what's been described to me as among the problems is we're talking about putting on rubberized suits,
Yeah.
where you're wrapping everything up with tape, gloves, boots, wearing a covering on your face,
Right.
and sealing that all off with a recycling air in some
Sure,
cases,
sure.
in environments where there's no air conditioning
Right.
and it's tropical. And it's incredibly uncomfortable. And the problem is not just that, but it's once you've treated somebody and you've left the room, you have to take all that off in a way that will not infect you or the people who are helping you take it off. So it's not just, don't they have protective gear, it's the environment in which this is happening. It's extremely challenging. And they don't have running water sometimes.
Right.
So it's a combination of things.
I heard with the outfits that they're wearing that it really requires training and it takes two people
Right.
to help someone don up because you
There's-
can't always see when you're doing something wrong. You need someone to stand there and say, don't do this, don't do that.
Well,
It's
right,
time consuming.
And so the masks fog up. I mean, it's really quite challenging. There's some very interesting videos online. You can look and see what it takes and how long it takes before you can even go in a room and then when you've come back out. So it's incredibly time intensive. Resources we can figure out. If there's will, there's money to pay for as many
And then what do you
suits
do
as we
with
need.
it once you take it
The
off?
waste has to be incinerated. I mean, it's really a challenge. All that said, the epidemic has not been totally stemmed, but the numbers are much, much lower. So the work has been effective, albeit too slow. But I see another hand, and then I'll come back to you.
What about the military intervention then? What about them, the people who came back? You don't hear anything about them being infected? Or
U.S. military.
Huh?
The U.S. military?
Yes.
They weren't, but I think mostly they were building clinics. They weren't,
less in the infected areas.
and they were less exposed to individuals. So they were really they were trying to build out infrastructure and ability so that those who were providing healthcare have places to do it. But as I showed you, that happened at the tail end. It was understandably slow, but it's nonetheless slow, and kind of at the wrong place, wrong time. Okay, yeah? I want to make sure there's not more here. Go ahead.
Okay, during the construction, they have the asbestos problem, so that's what they do, the same thing. They go
Yeah.
into, they provide tents or whatever. They go in dressed up with this type of a suit, go in there and remove the asbestos material, come out, take off, shower, and come out and do the same. So they do the same thing to prevent.
It's a version of that. It's a version of that. But of course, the difference is if you're exposed to asbestos, it's many, many years until you know that that actually has happened and you have health effects.
Yeah.
And you're not infecting other people, right? Your exposure to
No.
asbestos isn't something that you then pass on to others. So I don't know that it's any more or less effective what they've done with things like asbestos removal, but it just has a different level of risk associated with it for
That's true.
others.
That's true, but the method that they use
Similar.
it's a similar method, and they use it so we have a person who's knowledgeable go in
Yeah.
and inspects to make sure it's removed.
Yeah.
Again, it's
I don't
the same
think that
way.
there's a lack of knowledge about how to do it, but you
Yeah.
have to train people who are
Oh,
walking
definitely.
around doing it, and you have to do it in a way that will be effective in really challenging environments.
Right.
Yeah. So no one wants to be in a closed suit when it's 100
No,
degrees out.
no,
Okay, you
no,
get it.
no.
Yeah.
This case in Dallas where the nurse is suing the hospital because
Yeah, she
they
wasn't
didn't
properly
provide
trained.
training. When you think about the logistics of a very low risk of anybody coming into an emergency room being infected, and the cost to the hospital of stacking supplies, and each one of those suits that you're talking about is terribly expensive.
Yep.
And to stock enough of them to prevent an epidemic that may or may not occur
Yeah.
with a very low risk, the cost to the hospital is enormous. And the training is enormous, the time out of training for something that may or may not happen with a very low risk. So I think it'd be, it's really unrealistic to expect hospitals to be prepared in an adequate way for this type of epidemic. The best prevention is to keep it contained. I think what the Army did by sending those people over there and building those tents, even though
Yeah.
it was too late, but that was the right approach to try to contain it in an area, because you can't expect every little emergency room throughout the United States, with world travel being what it is.
Yeah.
Anybody can go into any little podunk center emergency room and infect the staff with, and there's no prevention, there's no cost-effective way to prevent that.
So one, I would say that absolutely you're right, and that realization came home, and what happened after the Dallas case was that all of the other healthcare workers, when they came back and if they were infected, they went to very few centers, right? They went to Bethesda, went to the NIH, or they came here to Hopkins, or there was a handful of places that were identified as Ebola treatment units in the United States, so that we wouldn't have this problem, right? So it turned out that Thomas Duncan was the first.
He wandered into that emergency.
It happened to
room.
be
He
that
could've wandered into any
he
of
came
them.
back from Africa, went to his family in Dallas, and then ended up in Park Lawn
There's
Hospital.
part,
But the
there's not
people in
much,
Texas
Parkland Hospital.
were
Sorry.
invited to have those patients treated in a tertiary or quaternary care unit. They refused. The hospital administrator said, we can take care of this.
Yeah,
I mean, so ego gets involved. too.
yeah, no, that's right. Well, and I've been part of conversations that I won't share with you about exactly that, where people said, we want these patients, and it was effectively said, no, you don't have the expertise, you don't have the infrastructure, we're not gonna let patients come to your hospital. So a very small number were identified as acceptable locations, and that's where the patients went. Bellevue, New York, NIH Medical Center, Bethesda.
Nebraska Biological Institute.
Yeah. Emory. Right. So, and here, yeah. So, it's probably, I don't know how many in the United States, but a handful, for exactly this reason. But it just happened, the first case ended up in Dallas, because that's where he went to see his family, not because he thought that was the best place to get health care.
even the nurse that was in NIH is suing, or at least
Yeah.
has,
Yeah. No,
whether it develops into anything.
Yeah.
But under the ideal, the best that we have is turning out to be a potential legal problem.
Well, and those, who knows what will happen with those particular lawsuits, but I think it points to you're right. We need to find the right places to deliver this kind of care. It makes you worry a little bit about what happens if we have a much wider spread outbreak of something that's, say, airborne, where we won't have the luxury of it being 10 patients. All right, let me finish up, at least with where we are here. So we have this question of trusted authorities and how we want to be able to say, yeah, the public health community is to be trusted in whatever they tell us the right thing is, the right behavior, how we proceed. We want the government to be trusted in terms of what they tell us the policy is and why. And we would like to be able to trust what we read in the media. Those are the things we want. Whether we're going to get there, it's not obvious to me. Right? We want there to be clear and consistent information from those who are communicating it to us. There should be some organized way to do that. And my earlier point about needing to be clear to people about what we're going to restrict in terms of their liberty and why, and then in return for that restriction, how we're going to make sure you're cared for. Right? So you may remember when Casey Cox came back, she was made to stay in a tent, right, next to the hospital, I forget what, near Newark, New Jersey, I think, New Brunswick maybe. That's wrong. Right? That's not how we should have treated somebody who went to help people in West Africa and exposed herself to some risk, when she returned, she shouldn't have been made to stay in a cold Mylar tent. Right? Whether we think we should have restricted her liberty to make sure she wasn't infected, okay, I can grant you that. But if that's the case, let's make sure she's in a comfortable, well cared for, she's got food, access to the internet, all the things that you would need to have a regular, normal life. And that's not what happened. So that's problematic in the way we responded. Yeah.
We also need to be educating these volunteers better.
Yeah.
So that they,
Yeah.
first of all, know what they're getting into when they volunteer. And second of all,
I don't
have a better idea of how to protect themselves.
Yeah.
For example, this doctor that came back had a girlfriend.
Yeah.
Now, one thing that I've heard about Ebola is the Ebola virus. You can't transmit it by most kinds of contact once you're no longer infected. But this virus tends to hang out in human semen
And we don't
for
actually
3
know.
months
Right.
after the person's symptoms have disappeared.
Yep.
So all these kinds of things need to be told to these people
Yep.
before they get on the plane.
It's true. And these are highly educated people, and presumably they're going with eyes open. But all right, you're right. So there has to be sufficient training, information, understanding, both before and after, but I would say we need to be better prepared so that there's a sense of, when you do something, whatever, whether you understand it fully or not, you're doing something quite heroic. In return, we're going to take care of you. And it's the same point, but a different version of it. That we sometimes say we're either going to let you do what you want or we're going to take away your liberties, and it's this kind of dichotomy. But we can support people, but at the same time restrict what they're allowed to do. So the example of making sure somebody has what they need and that they're comfortable, while at the same time saying, but for the public's health, we're going to restrict your movement, seems to be a way of going forward that doesn't really make it either or. Either you're free to move around or we're going to put you in quarantine. I think that's it, yeah, okay. So you've been very patient. Anything else you want to talk about this or other stuff? We've got a little bit into measles. I'm happy to talk more if that's of interest to you. Yeah.
Yeah, new diseases and new germs are entering the country all the time.
Yeah.
I'm very concerned about that. I'm wondering as individuals, because we can't rely on the government, we can't rely on the press. As individuals, how do we protect ourselves? Buttressing our immune systems, anything else?
I also don't want to leave with you the idea that you can't trust the government or public health authorities. I don't think that's 100% right.
Not what you said, that's what I'm
Yeah, okay.
thinking.
I don't know what to say about that. I think it's, the world gets there's more people all the time. We're living in closer proximity to animals. There's transmission of viruses between humans and animals all the time in increasing numbers. I think, this is emerging infectious diseases. It's something that we're going to be faced with for the foreseeable future. I don't know if there's any good answer to your question except to say, yeah, that's right, be aware. Yeah. I see a hand in the backpack. Okay.
What percent of the measles cases in this current measles outbreak were in fact vaccinated?
I don't know. I'm not sure I understand the question.
What percent of the current measles cases in this outbreak had been vaccinated for measles already?
Oh, the people who
The actual cases.
I don't know. So that's a question about how effective the vaccine is.
Exactly. Also, on the fatality rates of what percent of the lab confirmed
Yeah, that's a good question.
were in fact, which
We're actually right. So that's, of course, so let me go back to that chart. It's a good question. And then you have all sorts of, you want to know all sorts of things about the quality control of the labs and other things that I don't know and I'm not sure anybody actually knows yet. But that's all the things we're going to want to have a better sense of as we go forward. So, of the 3,500 and some odd total cases that suspected, probable, and confirmed, 3124 were laboratory confirmed, right?
Right, but what percent of those cases in fact died? What's the
Well,
fatality rate?
You see the total number.
Deaths, right.
You see the total deaths.
Total deaths, but what percent of laboratory confirmed cases died?
Well, so you take, I would say, take the 2348 and whatever that fraction
Right,
is.
but does that that is not restricted to laboratory confirmed deaths. It's only.
Right, so the
overall.
problem is,
Right.
in the second, the Liberia case, the number of total deaths is smaller than the number of lab confirmed cases, but that's because of, they don't have the infrastructure to confirm the cases. So we're not gonna know the answer that I understand the question you're asking, so we're not gonna get there.
That's greater than the laboratory.
That's what I just said, yeah.
cases.
Yeah, and that's because they don't have they don't have sufficient laboratory infrastructure. You're right, we want to know that. To understand what the fatality rate of this disease is, we want to know the answer to that question.
What was the R factor for Ebola?
2.
2.
Is that two extended over what period? Is it 2 per?
2 during the course of their
Now, what is the average?
infectiousness.
What's the average?
That's a short period of time for Ebola, it's much longer for HIV. That's why,
Like, is it 1 per week or something like that?
I don't know that we know enough about how long it takes to die once you've been infected, but it's much shorter for Ebola than it would be for measles, or than it certainly would be for Hep C or HIV. And that's part of what you have to factor in. So you're right, the R naught is low for Ebola, but it's compressed in time as compared to the risk of the lifetime of infectability of somebody with HIV.
But that information should be available.
Yeah, well, we don't know enough about Ebola yet to be as definitive as we can for other infectious diseases. I'm giving you a snapshot. You want to ask a question, Becky, or you want to be done?
Oh, no, I'm just going to give,
You're giving me the high sign.
I'm giving just in a few minutes.
Wrap up soon. Okay.
Who is financially responsible for treating the volunteers who became ill with Ebola and come back to the United States? I mean, I can't imagine what it costs to go to a biological containment facility
Yeah.
for 3 weeks.
So who bore those costs is your question.
Right.
There's a descriptive answer to that question, which is I'm sure the federal government, but that's a different question than who should.
It seems to me that should be part of the package of volunteering.
Yes,
It's-
and
the
I
information
think,
should be known.
I don't know this for a fact, but I would bet dollars to donuts that those individuals certainly were never sent a bill.
They're often NGOs, right? So
Yeah, so MSF or they're, some kind of charities that sent these people over. I'm sure they have insurance policies, but the question is, what does it cover infection by, that would require isolation in a biocontainment facility? I'm guessing in these cases, because there's so few, that the government absorbed it, but I actually don't know the answer to that. There's a should question in there too, not just who did, right? It's who ought to. And that's a really important question. I would say is, again, part of this reciprocity. If we're thinking it's appropriate and acceptable for people to go, then we need to be able to make sure that they're cared for when they return, however that happens. Yeah?
Going back to the slide about the empty clinics, now those clinics can be used for something
Yeah,
else.
no, that's right. We built out
Low resource
infrastructure.
area. One of the reasons they're empty though is because no matter what you're treating in that area, if there aren't enough doctors, enough nurses, or anything that are in the
I
country.
think it may be partly whether
So
we're
that,
filled
you know,
up or not,
this-
there
this-
weren't patients, but
This is not just
Yeah.
a bricks and mortar problem,
true enough.
it's way beyond that.
Yep. All right, one more, and then I bet Becky's going to say we should wrap up. I can see her looking that way in the back. Yeah?
who should, in your opinion,
Yes.
who should have the authority to say things like people can't come, we have to hold the people coming back from West Africa? Should CDC have it? Should it be at the state level somehow?
About who
Where
should-
the authority be?
For
To make
travel?
these- Excuse me?
So for what was the group?
The thing is, Christie and Cuomo said you can't come in.
Yeah.
right? And who should be providing those rules? And does the CDC really have any authority in these cases?
There's a discussion among the public health authorities, the State Department. It would be at the level of the White House, actually. I'm sure that they would decide it in a case like this. But there are all sorts of, planning has happened in relation to pandemic flu about these kinds of questions. And what's interesting about our system is it's very much state by state. So the public health authority resides, there's federal level authority, but there's also state level authority. And the police power of the governors of states is different. So that's something that's an interesting question, frankly, that people have examined, but there is not a good answer about what would happen. And, could we close a border between Maryland and Virginia or Maryland and Pennsylvania? No. people live in Pennsylvania and work in Maryland and vice versa, right? It would be very, very difficult to do.
Didn't we go through this with typhoid Mary, though?
Sure, I mean, you're right, these kind of public health questions are not new. And it's a good story in some sense that we haven't had to confront it for a very long time, right? So that's maybe the positive way to end. We've done a very, very good job of keeping epidemic outbreaks at bay for a long time.
They used to quarantine people.
What's that?
They used to quarantine people.
Right, well, if you
Go quarantine.
flu, typhoid, I think where quarantine was the mode of choice. Tuberculosis, we once in a while still do quarantine people. But luckily there isn't much tuberculosis in this country anymore. So part of this is a story of successful public health. But cases like the Ebola story point out that we're one outbreak away, one mutated virus away from needing to figure this stuff out again. So I guess with that not very optimistic comment, we can be done. Thanks to you all.